Hello and happy Teach Me Tuesday. Welcome to the second Tuesday of December. And today we are going over some neonatal labs and more about what it means for you as a bedside nurse and what to anticipate as next steps. If you've been here for a minute, back in June, we did some neonatal labs. We're going to go over a similar amount of those today. We're not going to talk just about the normals. I actually think I got stressed when I was doing that because I do think the normals can be so different depending on the day of life the baby is, how many weeks old the baby is, and trying to give you like a table or a chart to say like this is exactly what's normal every time felt tricky. So today we're going to talk more about what happens when the lab falls outside of what you all consider normal at your center. And I hope that that's helpful to you. This was a requested topic to really kind of dive deeper into neonatal labs. So we're going to go through the major ones today. We have already done blood gases this year exhaustively, so I am not going over blood gases today. If you need me to link you anywhere to help you with blood gases, you can find them on this page. I think we did it for like 4 weeks and even about ventilation strategies. So there is a ton about neonatal blood gases if you need it. But really what we want to know with our neonatal labs is it's not just about the number, right? It's looking at the number in comparison with the whole picture and kind of creating a critical thinking framework. What do I do next? What would be something I would escalate for? What might we be able to watch a little bit longer? What could be a text or a message to a provider versus a call, I need you at the bedside now type of thing. These skills also directly impact what's going on with the baby. We're going to talk a little bit about fluid balance, which, spoiler alert, we're going to talk about next week majorly. So, and how that impacts our respiratory system. And then also what's going on with nutrition, our kidneys, and then escalation of care. So as you see, I have right on this slide, I want to remind you that this is supposed to be supplemental education to what you are already getting on your unit. Your unit's policies and procedures should always supersede anything I tell you. And if you have a guideline, one lab we're going to talk about today is CRP, and I can tell you that CRP levels vary as to what is abnormal greatly depending on your lab. So take that with a grain of salt. Here's our framework that we're going to be thinking about. Step 1, is it truly abnormal for this gestation and this day of life? Sodiums are wacky in the first 3, 4, 5, 6 days on extremely low birth weight infants, which we're going to talk about a little bit today. So we would be thinking about that. Your sodium, your chloride level, your CO2 levels can be wacky on your BPD kids, your big post-term kids. So you really got to take that into consideration. Number 2, how urgent is this? Is this a stable trend? Did we go from a potassium of, 4.8 to 5, or did we go from 5 to 6.5, right? There's a big jump and there's a little jump. What system does this affect the most? What bedside assessments must change right now? What do we need to do? What do we need to look at? What do we anticipate being abnormal with the lab that we see? And then what provider communication or intervention is needed? And that's what we're going to go through today. So let's start with our CBC. Our CBC can feel stressful because we do accept quite a wide variety of numbers. I am most comfortable talking about hematocrits because that's what we have used in the units I have worked on to determine if we are going to give a blood transfusion. Hemoglobin, also a great value. But what you really are going to see here is either this low hematocrit or high hematocrit kind of dictating what to do next. Again, I've given you some ideas of what maybe would make you be triggered as to thinking something's abnormal. So if you have a crit less than 30, maybe that's some anemia going on. Maybe you've got some blood loss. Maybe you have some hemolysis. If your crit is about 30, in the first 3 days of life on an extremely low birth weight infant on a high frequency ventilator, that is very different than a crit of a 8-week postpartum or post-gestational age, right? They've been alive for 8 weeks and they're on low flow nasal cannula. So those values are not equal, and that's why you have to take this whole clinical picture in together. What you're going to do when these values fall outside of normal is look for tachycardia, apnea, increased oxygen requirements, poor weight gain, poor feeding. Have you done a reticulocyte count? The retic count is telling you if your bone marrow is pushing out new cells. And if your retic count is good and you transfuse a baby, it actually says to the bone marrow, like, I don't think I need you today. So the bone marrow starts producing less red blood cells, and then you get into this cycle of kind of needing to do this blood transfusion as a bump. So think about that and think about what a symptomatic baby is going to be. And of course, iron supplementation and minimizing your lab draws is going to be so helpful. If the baby's polycythemic, we get into this range of, will they need an exchange transfusion? Are they severely dehydrated? This was a major thing that came up during when delayed cord clamping became more popular, is where we're going to have all these polycythemic babies that we had to give extra fluids to, or would need to come to the NICU for extra fluids, and really they didn't see that. So polycythemia can happen in twin to twin, and as you may know, the recipient twin, the twin that receives more blood, has those high levels, is often the sicker twin because it puts more work on their heart. So just something to think about. And seeing as that we're already at 5 minutes, I feel like this is going to be a long video, so feel free to pause me and come back. Looking at our CBC, we also have our platelets. Again, I've never seen someone transfuse just straight up for platelets under 100, but it's a good 100,000. It's a good number to think. Most of the time I'm seeing transfusions happen when the baby gets between 30 and 50,000 on their levels, but it's also going to depend on the trend and what's going on with the baby. You can see changing platelet levels in babies that have NEC, so that's often a warning sign to help the provider dive deeper. You want to be looking for bleeding, petechiae, oozing. If your platelet has a sudden drop, we are doing those head ultrasounds to look for IVH. That is a big red flag for IVH. So, and then we may minimize our invasive procedures. So the transfusion is going to happen if the baby's bleeding, if it's critically low, if it's a downward trend that's trending quickly down. That's when you're going to see an intervention for low platelets. On our WBCs. So again, this is one where it's like, yep, if it's a really high number or a really low number, but we've had really low numbers on very healthy babies. So especially newly delivered babies, it can often reflect what's going on with mom. So it can be tricky. What I would say is you should be looking for that left shift. We've talked about left shift multiple times, but remember what a left shift is saying is, hey, the bone marrow is panicking because it senses there's an infection. It sent out all its cells that were ready to go. It sent out mature cells, and now it's sending out immature cells. So I always compare this to like an army. At the beginning, we send out our soldiers that are trained and ready to go. And then as we need more and more soldiers, because there's more and more attacks, so this sepsis is attacking, we send out people from basic training. And that's what your young cells are. So that's what a left shift is. It's shifting more into the bone marrow, so it's shifting towards the left, towards the immature cells. The more immature white blood cells you have, the more likely it is that your baby is sick. When you have abnormal white blood cells counts, you want to be looking at other things like temperature instability, apnea, perfusion. Do we need a CRP? Do we need a culture? What is our overall sepsis risk? And we're going to talk about CRP in a minute. So our BMP, our electrolyte panel, our iStat with a Chem 8, our Chem 8, whatever you're doing to get your electrolytes. Let's talk about our sodium. Basic understanding is your normals are going to be 135 to 145. Again, that's your basic typical range. Low sodium usually means you have too much free water. High sodium means the baby is dehydrated. These are always backwards for me, so we're going to really dive into that on our next slide. But what you can anticipate next is looking at your total fluids, your urine output, and your weight if your baby's getting weighed. We would anticipate a fluid adjustment. No matter what's going on with your sodium, anticipate fluid adjustments and maybe many in your shift. You might need sodium supplements or sodium restriction, and then you're going to have increased monitoring of your daily weights, your strict eyes and nose. I've done Q12 eyes and nose where we're like really watching what's going on and making adjustments rapidly. And then your daily weight versus your expected physiologic weight loss. I'm going to remind you that most people that are doing midlining positioning for 72 or 96 hours are not weighing during that time because we anticipate the baby to lose weight and we are going to use their birth weight anyway. So if you're during that time, I don't think you would suddenly start weighing the baby because of your sodium levels. But let's dive in deeper into sodium because I do think this is what trips people up. This is what I got the most questions on after I've posted about labs. So remember, we have intracellular and extracellular sodium, water, all of the things. Sodium is the primary extracellular electrolyte. So when you have a high serum sodium, hypernatremia, water has shifted out of the cells and has caused cellular dehydration. When you have low serum sodium, so hyponatremia, you have water shifting into the cells. So those cells are swelling. It can cause cerebral edema. So when we are hypernatremic, our levels are above 145, right? Whatever that might mean for your baby. Typically, it's because we have an inadequate free water intake, increased insatiable water loss. This is why our babies are on humidity. This is why we are in a giraffe. If they're on phototherapy, it can increase your risk for that. Of course, this can happen with diuretics or high protein TPN, but primarily we are probably going to make an adjustment to your humidity and to your fluids. So be prepared for that. And it's not just that you're going to turn your fluids up. You're probably going to be weighing something in. If the baby can tolerate D5, we would do that to keep their calorie content up. If not, we would weigh in something like sterile water into the fluids. I don't know why I'm like stumbling over my words here. If the baby's hyponatremic, so their levels are down to 135, that's when you're going to start seeing fluid restriction. So your total fluids are going to go from maybe 140 down to 120. And again, we might be making actual changes to your TPN or giving them some more sodium containing fluids, like giving them a normal saline bolus. But we really want to be getting that concentrated fluid in because we want to restrict how much free water they're getting. So I'm hoping that this is helping you. Again, if you need more about sodium, please reach out to me and stay tuned throughout the week. On that same electrolyte panel, our potassium, again, typical range is 3.5 to 5.5. One thing that's really important that I've listed down here is thinking about what your source is for the blood and remembering about your heel sticks and really trying not to be scraping the heel, squeezing. And if you're getting high levels that don't seem to be matching what's going on with the baby, you may need to draw the blood in a different way to make sure it correlates. So if they're not on a cardiac monitor already, we would get them on one. A high potassium is often from a tissue injury or acidosis, so you might need to correct that first. Really high potassiums, we are going to correct. You can correct it with albuterol. You can use insulin. So those are some things you may see as the bedside nurse in this situation to treat your high potassium levels. If you have low potassium, that's often from GI loss, so vomiting, diarrhea. I've seen this in neck babies, and so we would be giving them some replacement with that, whether that's via their TPN or another way. Other labs you might see on your BMP or your chemistry labs would be your glucose and then your BUN and creatinine. So we've talked about glucose a lot. I did put it on here because I just wanted to keep it as a reminder. If you have low blood sugar is often a sign of sepsis. We need to be giving them sugar immediately, whether that's in a D10 bolus, increasing from D10 to D12.5 or D12.5 to D15, whether that is feeding them if they're more of a term baby. The main thing you would want to do here is, or reminders, is if you are going on sugar above D12.5, you need a central line because that sugar can be really caustic to the veins. You want to make sure you check your blood sugar 30 minutes after any IV glucose is given to that baby, any change. So if you're just going up in your total fluids, you should be checking that. Those swings can happen rapidly. If the blood sugar is high, you may need to be giving insulin. Again, if your baby is on TPN or TPN and something else wide in, you may be whining. What if your TPN dextrose is 10 and your wide index, and you need to change your GIR, your glucose infusion rate? I've heard it called DIR for dextrose infusion rate, but your GIR, you've got this bag of D10, we want to get your GIR down, we're going to probably in a bag of D5. So again, these rapid fluid changes that are going to require critical thinking to know, why am I doing it? Where is it going? Making sure you're tracing from machine to baby so you don't swap the lines. I've seen that on a med air before, right? Where they ran the D5 at the TPN rate and the TPN rate at the D5. So tracing your lines all the way down so we can safely change that sugar. With your BUN and creatinine, we are really thinking about what's going on with our kidneys. We're thinking about dehydration. So we really need to be looking at our urine output. If you are not calculating your urine output every shift, you should be. And at the very least, your EMR probably is doing it for you. So go look there. CRP. So CRP is such an interesting lab. I've had many people ask me about this. CRP does not rule in or rule out a infection. In fact, a CRP is a measurement of inflammation, and that can happen when you have an infection, absolutely. So you could be trending this, and if it's extremely high, and I say like in the hundreds, but for some people that might make them pass out, I have seen the number 1 be considered high. I've seen the number 10 be considered high, and I've seen the number 100 be considered high at 3 different NICUs I worked at. And that's because of where your lab is putting the decimal point. So be sure to know what your lab considers normal and then go from there to say, okay, this is what I'm noticing. I also have temperature stability. I also have increased apnea and bradycardia. So we're going to get a blood culture. We're going to probably start some broad spectrum antibiotics. The blood culture can take up to 48 hours to grow. We know that. And during that time, if the baby's getting sicker, other labs are going up, you might need to be doing a lumbar puncture. You might need to do urine, right? Look for other sources. Trach aspirate if the baby is intubated. What else could we be looking at besides just blood for a high CRP level? And that's where I think the critical thinking really comes in with the CRP, is that it's trying to alert you that something's going on, and we might need to be detectives and figure out what that is. So those are the major labs I've been asked about to really kind of dive into. And what I wanted to come back to is this idea of when to recheck and when to escalate. So rechecking, if it's mildly abnormal but the baby looks good, if you're trending, if there was any fluid adjustment made, you want to escalate immediately if the lab change matches what's going on. If your baby is jittery and now their blood sugar is abnormal, if their urine output has ceased to exist, and your BUN and creatinine and your sodium are changing, we need to escalate immediately. If your hematocrit or your platelets randomly drop down, we need to be looking at head ultrasound. So we need to be escalating immediately. Our job is to really reassess the patient, to use SBAR to know what our trends were. You cannot call a provider and tell them one value unless the baby's 1 hour old, okay? You need to say, hi, this is Lisa. I'm calling about my patient in room 5. I have a critical lab value for you. I have a sodium of 152. 6 hours ago, it was 148. 6 hours before that, it was 142. So it's going up 6 every 6 hours or whatever. We have made this and this change. I'm wondering if you would like me to wind different fluids, if you want me to stop the TPN and just run straight D10, right? What could we be doing? Have something ready for them. And then always be mindful of kind of pairing your labs with what's going on with the baby. Parent education, it's tricky. Nobody wants us to be poking their babies, right? We should be reducing pains and pokes as much as we can. So what can we do to tell them why we're doing it? If they're on phototherapy, that we need to be checking that bilirubin more often. We've done a whole phototherapy and hyperbilirubinemia lecture this year, so go check that one out if you have questions there. Maybe they're like, why do you have to check them so frequently? And that's because babies can change quickly, and we don't want to get too ahead or too behind, which is something else. When you're making all these changes, sometimes they're not going to feel like a lot, but that's because we don't want to ever swing the baby in either direction with our electrolytes, with our blood sugar, even with our hematocrit, right? We don't want to be making dramatic changes in any direction. So what are some red flags? I think that critically high or low potassiums make me nervous because it really tells me that something might be going on with the baby, especially neck. Same thing with platelets, and critically low platelets make me concerned about the head. Your rising creatinine with decreasing urine output. Kidneys are hard to reperfuse. So kind of once we've lost them, it can be tricky to get them back. So that's why I watch urine output so closely. Rising CRPs or really high CRP. Again, urine output. I feel like I've said urine output many times today. So hopefully you're paying attention to your urine output. Metabolic acidosis, hypoglycemia, despite increasing that GIR, right, that glucose infusion rate. We are going to talk about glucose infusion rates next week because we're going to talk about total fluids, so come back for that. And then lab values that are changing. Any abnormal value that's paired with apnea, escalating respiratory support, poor perfusion, check your cap refill. It's December, right? Do you remember in January? Do you know what we did? We did back to basics, and we went back to assessment and talked very blatantly about the importance of assessment, and capillary refill falls in there. So I hope you are still doing that from the beginning of the year. So to recap, we're at 20 minutes. I've pulled it together here. Labs are not just numbers, right? It's really can be a warning sign. It can tell us what's going on with the baby sometimes before they can tell us themselves. It's really important to know what your center calls normal labs. Having a reference sheet, whether that's an Epic, whether it's in your EMR, whether it's at your nursing stations, thinking about what the baby's gestational age is, post-gestational age, what their current status is. Remember, what we accept in a 3-day-old ELBW is going to be very different in a, 3-month-old baby. So keep that in mind. Watch your trends. Trends are telling you more than any one single value can. So this is going to help you intervene faster and improve your outcomes for all these babies. I hope this was helpful to you. If you have any more questions, please reach out to me via email or on social media.